But there were three people who believed Glenn's vision and shared it and helped to promote it. And I'm going to invite them to the stage now. Steve Leeder, who's Emeritus Professor of Public Health and Community Medicine at the University of Sydney, and made sure early on he moved from Camperdown to Westmead. He moved out to the western suburbs because he knew epidemiologically and socially that's where he should be. Professor Stephen Colagiuri, who's Professor of Metabolic Health Medicine at the Boden Initiative at the University of Sydney. I often say in safety and quality in healthcare, we tend to focus on surgeons because surgeons kill people very quickly, very days. And I argue that why don't we talk about endocrinologists because they kill people slowly. But Stephen is not one of those endocrinologists, nor are the hard-working endocrinologists who get involved in the case consultation, which is core to the activity of Western Sydney Diabetes. And last and certainly not least, Walter Kmet, who's moved to the dark side. He's gone from primary care to high technology medicine. But nonetheless, we will still welcome Walter as the CEO. Were you the founding CEO of West? You were, weren't you? No, not. Your board chair is telling me the truth of the matter, but certainly was involved. And you cannot do this without primary care. So Steve, just take me back to the beginning. What did it look like epidemiologically then? And in terms of formulating a way forward here, which wasn't really seen elsewhere. I think if you just turn that on, it'll all work.
Right at the beginning, it was pretty clear from what we could discern in the patterns of health and illness in Western Sydney, especially beyond Westmead Hospital into the Western Sydney community, that there was a lot of diabetes, and by that I mean a lot of manifest diabetes as an illness and a lot of complications. And the surgeons at Westmead Hospital were amazed at the number of amputations that had to be performed for people with diabetic blood vessel disease, and the ophthalmologists were commenting that they saw a lot of people with eye disease that could be traced to diabetes. And so right at the beginning there was a discomfort both among the healthcare professional community.
And this is, just to wrap, and this is without even talking about stroke or coronary heart disease.
Yes, well, that as well, but it's pretty common in its own right without any help from diabetes. But if you go into the origins of the blood vessel disease that leads to limbs needing to be amputated, diabetes has got an unenviable but distinctive reputation. So just at sort of first glance, without the aid of any surveys or sophisticated statistics, we could see that there was a very big problem with diabetes.
And the causes? Because you tend to think, oh, it's obesity, it's bad diet. But, in public health, you talk about upstream causes.
Yes, well, it was fairly apparent that a lot of the diabetes that we were seeing was of the type 2 variety, which can be the end product of a disordered metabolism relating to years, if not decades, of abusive eating, I'd call it that, and significant overweight and obesity. So the constellation of metabolic problems that we were seeing suggested that there's a lot to be done, and a lot of those things originate in the lifestyle and the family patterns and the personal patterns of behaviour. They're not things that you can write a prescription for or give an injection for, but they're things that relate to the individual's place in society. And I'm not saying, therefore, that it's all the problem of the individual, because so many of those social circumstances limit or promote good or bad health-related behaviour. And we need to be very sensitive to that and not say silly things to people who are not really in a position to move much. If you're getting up on the road at 7:30, part of your employment and you don't get home until after it's dark, and then that individual doesn't want to hear about happy chats of going for a jog before the day starts. Or the woman who's having to care for 2 or 3 children on her own, flat chat. So the recognition of social factors and personal and family factors in the origins of diabetes is very important, because they do give us a clue about what theoretically could be done. But the practicalities of actually doing something require a lot of sensitivity and reach into the realm of politics and economics, which is real tiger territory. But it's partly where we have to go.
Stephen, as in Colagiuri, in some senses, prior to this, not experiment, but this innovation, this system innovation, I mean, endocrinologists were really stuck within their rooms or in hospital outpatient clinics. To talk about the challenge of bringing the specialist expertise to primary care and to the community at large, and building on what Steve's just been talking about.
Obviously, the majority of us
Might wear it's old-fashioned.
obviously the majority of us don't know how to use a microphone, but that's another story. So the majority of endocrinologists basically do practice one-on-one. When they see a patient, they try and do the best they possibly can for that patient. But I guess I'm fortunate that that I was actually involved with the broader challenge of trying to do something at a more community and public health level, and that occurred through the development and contribution to national diabetes strategies, where it was clear that although it was very important for the individual that we saw to do the best we possibly could, there was more that needed to be done to actually stop those people coming into our rooms. And that was what, for me, motivated me when Glenn and Steve and others asked if I could sort of be involved in a small way here. It was an opportunity to take all that theory that we write about in national strategies and to actually try and implement it. Because although we've had a whole series of national strategies, at least 4 in the last 20 years and the most recent one in 2021, it's very difficult to actually implement what's required at a community level to actually prevent diabetes or to actually provide the models of care, levels of care that people require beyond what you can just do on a one-to-one basis and address all the issues that Steve Leeder has actually just mentioned.
Now, the problem seems so vast. I mean, some surveys would suggest 30% of the population with pre-diabetes, 15% with frank diabetes when you actually go looking for it, in a very large, very diverse population. Probably a little bit more concentrated now than it was 10 years ago. But what did you see as the biggest challenge?
Well, it's difficult to say what the biggest challenge is, because the whole thing was just a big challenge. And I think
but people, that wasn't news, but people were overwhelmed by that challenge rather than taking action.
Yeah, no, so I think that I think that one of the main things that, to again just refer back to this program, is that it was first of all decided that sure, it could be addressed if you just took it a bit at a time and a piece of it at a time. And the fact that we're here 10 years later, the fact that it was obviously acknowledged at the beginning that it wasn't going to be done over a 3-year period, which is a normal political cycle. And I think that the program has actually addressed all the key issues that are involved with trying to reduce the burden. This issue about, obviously, prevention, screening. There are a whole stack of people out there who obviously one will hear about more and more during the evening. And what this program has contributed in terms of identifying those, getting them to care, and then there's the actually improving the model of care, because even as a single practitioner, it's just overwhelming trying to do everything that's required even for an individual, let alone all those people who never get near the sort of service that they require because they don't know they've got diabetes, or that they don't have the access, or they can't afford to go, or they can't see dietitians, etc.
But the temptation then presumably would have been, well, let's do a population-based screening program, but they don't work in type 2 diabetes, do they?
Well, it's a case of, I don't know what you really mean by don't work, because I think to encourage people to think about diabetes, to actually go and get tested, does actually identify people who have a problem and therefore can start to address it. So sure, you know, I mean, we don't really recommend that the whole population be screened for diabetes. It's more the high-risk people, and of course there's a lot of high-risk people in this area, but it's a step. It's the first step towards getting to the sort of care that one requires in order to do something about the problem.
Walter, general practice in Australia has been described like herding cats or kangaroos, and that was your role as CEO of Went West to corral. But there's always been a core group of highly committed general practitioners in this region, has there not?
That's absolutely right, and first and foremost, I guess being here today, meeting a whole lot of the people that made a contribution is a great honour. I mean, it's been 10 years as we're all here to celebrate. It's great to see all the faces that made so many contributions to us here 10 years later, and I haven't seen Michael Fasher, by the way. He might be around here somewhere, but it's people like that if we talk about the herding cats, there are people really willing to step up and take a system approach. And I think it was mentioned earlier by you, Norman, about governments. Well, governments won't solve problems, but partnerships will. So when we looked at the problem that we had, some of the problems that we've just discussed, it was never going to be done by a doctor, whether it be an endocrinologist or a general practitioner working in their own office. It wasn't going to be done by one part of the system working on its own. It was going to be done by different silos, as you would have them, different silos coming together, perhaps people breaking the rules around the way each parts of the health system should work, and forming partnerships across the various parts of the health system, the human system, and indeed our community, to solve the problem, because it wasn't ever going to be solved by a single general practitioner, never going to be solved by a single endocrinologist, or probably never be solved by a medical person, frankly. But at the end of the day, our role, our obligation, certainly if we talk about Went West, was to encourage those partnerships to take place, for people to think about working as a system, as Di Halloran so often and so forcefully pushed over many years, operate as one system, as if you are one system. And I think the challenge for us has been to do that. But I think the fact that willing people were in that system to step up, including some of those herding, some of those cats you talk about, including the specialty of endocrinology at Western Sydney Local Health District. There were specialties at Western Sydney Local Health District that didn't want to play in this kind of space.
You shocked me.
We had 3 specialties actually. The one that stepped up was endocrinology, I have to say, and the others had every opportunity to do exactly the same thing, and that's why we're here.
Now, people talk increasingly about the financial incentives, the financial models, reimbursement, and it just works against, at every turn, it works against integrated care, it works against continuity of care. If you're an endocrinologist in private practice, or indeed a general practitioner, you're not properly remunerated, if indeed you're remunerated at all, for these activities. How did you get it going, given people weren't going to make money out of it?
I think the first conversation I had tonight, someone said to me, gee, you've got a lot more grey hair. I'm not sure where that grey hair came from, or the lack of hair came from.
It's only from Macquarie Health, it's not from Went West.
Absolutely. But I would, dealing with all those specialists perhaps, but I think there has to be leadership within the system. I think one of the tenets around being able to do things differently is for people to think outside what they're dealing with on a day-to-day basis, and begin to provide leadership around some of the issues that perhaps so intuitively you shouldn't do. One of those in diabetes is team-based care. And how do you have team-based care if everyone is incentivised individually? well, you know, I think we have to as a system, and certainly Danny at the local health district, we as a primary healthcare network and others, put money into people to behave in different ways, to actually have incentives to do things differently. So we were willing effectively to put our money where our mouth was for people to be incentivised to behave actually as intuitively you wouldn't otherwise.
I want to finish now with just looking forward. I mean, we do have a panel right at the end about looking forward, but I want to hear from you three about looking forward. The focus, as you've all said, this was not going to be achieved in 2 or 3 years, not even going to be achieved in 10 years. And a lot of the focus has been on secondary prevention, just getting people detected, managed, reducing the complication rates. Primary prevention, which Jim's going to deal with in a moment, has been late to the party. Where do you see the high priorities for moving forward in terms of tangible action? Steve?
Well, I think first and foremost there needs to be the definition of a sort of overarching strategy whereby we do move forward. And I'm very impressed with what can be done for a huge number of people when small effective changes take place. I'm just looking up the hall now to the 2 kilogram challenge poster. Not going to give it a prize or anything like that, but it's a good example, I think, of identifying something that's within the range of doability that might have great impact across the majority of the at-risk population you've spoken about. Healthy food choices clearly is another field where education of the population is very helpful, so that they can make choices between competing products, if you will, on the basis of their health benefit. When we started all of this many years ago, there was a program called Healthy Hearts West, and we had at an open day at Blacktown Hospital a caravan with an open side panel and various varieties of food which were clearly unhealthy. The sausages and God knows what all lined up. And the number of people that came to that caravan asking to buy some of these products was just amazing. So there was clearly a huge gap in what we'd call nutrition literacy. It wouldn't be all that difficult to tackle little by little. And while we're waiting for the new dawn of primary prevention and community reformation and all the rest of it, we may be waiting a long time, but those are identifying those little things that can be done, pinned on the back of an educational initiative, deserve a lot of thought for the future.
Stephen?
So I think the program has obviously achieved a lot, and if it continues in the same vein, it's going to achieve a lot more. And in terms of the future, I think there are 2 things. One is to maintain strong leadership, and obviously the program has had a group and Glenn as a driving force, and I think that that's necessary, and I don't know how long Glenn intends staying in the role, but I hope it's a long time. But if not, to ensure that there is a very strong succession plan. And the other thing is, I think, to maintain the integrity of the program. What's happened around the world and in Australia is that the programs, especially ones that are successful, start to be diluted. And for very good reason. I mean, obviously diabetes shares many risk factors with other conditions like cardiovascular disease and dementia. But still, there are many things that are really specific to diabetes. And what's happened around the world is that the programs then say, oh, we'll then do cardiovascular disease, and then we'll do dementia, and then we'll do stroke, and suddenly the diabetes focus is lost. And I think it's really important to make sure that the focus is maintained, even if other things are sort of added, but as long as the diabetes part doesn't get diluted.
Walter?
So perhaps I might pick up Jim's mantra from a bit earlier and create a bit of discomfort. I think the thing about the future is really the thing that we started with, and that is to rebalance the system away from the acute side of health and really back to primary care in the community. And I think that is really the future success of this program, as we've done, as the program has done. You know, the big steps that the local health district took, and Glenn and others in the leadership team took, was to say, well, we're going to move some money away from this acute end and back into the community, create capacity and capability in the community, and try to attempt to solve problems in that way. And I think, to me, that's still the future. We have to rebalance a system away from what we see as the end point and to the beginning point of some of these things that have been are working well now, and I think can continue to work with that support.
There you are, a leader of a private hospital cutting his own throat commercially in front of this audience. Could you please thank our fantastic panel?